I'm going to be presenting our QI project exploring the protective benefits of GI bleeding prophylaxis in patients initiated on dual antiplatelet therapy after ACS. This was authored by myself, Dr. Nzube, Ekpunobi, along with Dr. Batoul, Dagher, Dr. Sandra, Wijekularatne, Dr. Jaraad and Dr. Erica St. Lawrence. Fairly recently published out of the Department of Medicine at Detroit Medical Center, Detroit, Michigan, partnered with Wayne State University. So let's jump into the background here. We'll focus on GI prophylaxis, which is what many of us are very familiar with. However, it does tend to be some of the most inappropriately prescribed treatment in the inpatient hospital setting. Indications for GI bleed prophylaxis typically include those who are at higher risk of GI bleed while in the inpatient setting, such as those on long-term steroids, mechanical ventilation for 2 days or more, suffering from CNS or burn trauma, have a history of GI bleed in the past year, or admitted to the ICU for over a week, or have a coagulopathy. Despite clear guidance to the contrary, however, GI bleed prophylaxis is used pretty much as a general prophylactic treatment, somewhat similar to VTE prophylaxis in the inpatient setting. Unfortunately, however, GI bleed prophylaxis has its risks. It's associated with the increased risk of pneumonia, osteoporosis, C. diff, and more. So given these risks, the indications are somewhat limited. However, we believe it's worth exploring whether there's a benefit to expanding these indications to patients who may be at high risk of bleeding due to recent initiation of dual antiplatelet therapy after ACS. So the aim of this study was to study the efficacy of the GI bleed prophylaxis for patients placed on DAPT following ACS. Our null hypothesis was no significant difference between those off and on GI bleed prophylaxis. But we did posit as an alternative hypothesis that there'll be a superior net benefit. So we applied a retrospective cohort analysis to explore our primary outcome measure, which was the incidence of acute GI bleed requiring inpatient management 6 months following placement of dual antiplatelet therapy. And we selected random patients who suffered from ACS within the past year at DMC Huron Valley in Michigan. Our cohorts, including those placed on dual antiplatelet after ACS with either PPI or H2 blocker as GI bleed prophylaxis, versus those not placed on prophylaxis. We excluded those who suffered an ACS and expired within 12 months of the event. So the results we obtained from a list of 110 random patients were that about 76 of those patients were placed on dual antiplatelet therapy following ACS. We did collect data between the 1st of January and the 31st of December of 2021. And we had a 6-month bleed out time for potentially bleeding events. We saw that among the group placed on DAPT following ACS, 40% of them, about 39.5%, received GI bleed prophylaxis, while about 60% did not. And then among the group receiving the prophylaxis, about 10% of them actually had GI bleed events within 6 months, while only about 4.3% of those not placed on prophylaxis had GI bleed events within that same time frame. So that was actually pretty interesting. So in our discussion, we did highlight that our data did fail to actually reject the null hypothesis. It suggested there was no significant benefit confirmed or conferred in routinely placing patients on long-term GI bleed prophylaxis following initiation of dual antiplatelet therapy, as bleeding events actually between the groups were fairly similar. In fact, there could be an argument made that not routinely placing the patients on GI bleed prophylaxis, if our results are valid, of course, would actually confer a benefit in reducing GI bleeding events. However, of course, this study had major limitations, including unreliable data regarding compliance with dual antiplatelet therapy or GI bleed prophylaxis on discharge, lack of distinction between GI bleed events while inpatient following discharge. Selection bias due to poor randomization, which didn't really take into account demographic data such as race, sex, age, and socioeconomic status, limited sample size, no distinction between our various P2Y12 inhibitors, and the fact that GI bleed events were only recorded of patients, as well as providers not only recognize them as such, but they presented for treatment at a DMC hospital, which limits definitely the scope. So given those considerations, we believe more meticulous study in larger, broader, more diverse patient populations would be necessary before hoping to expand the indications for GI bleed prophylaxis among patients placed on dual antiplatelet therapy following ACS. And those are our references. So I hope you found this QI project to be insightful and helpful, and hope you got something out of it. Thanks so much for your attention.